Welcome, I'm Dr. Douglas Wingate, Integrative Neurorehabilitation Specialist. In this video, I want to talk about insomnia and sleep disorders, and specifically about what the neuroscience of sleep actually shows us about why so many people can't sleep, why standard approaches so often fail, and how Neurogen brain balancing targets the measurable electrical disruptions at the root of sleep dysfunction. This is not about sleep hygiene, this is about the brain. Let me start with the scope of the problem, because insomnia is systematically underestimated as a health crisis. Between 30 and 40% of adults report significant insomnia symptoms, making it one of the most prevalent health conditions in the world. Around 10 to 15% of the population meets full diagnostic criteria for chronic insomnia disorder, with symptoms persisting at least 3 nights per week for 3 months or longer. In the United States, that represents roughly 50 to 70 million people that are affected. The economic impact is also staggering. An estimated $45 billion annually in direct costs, and far more when indirect costs like loss of productivity, workplace accidents, motor vehicle crashes, and the downstream medical costs of insomnia-driven comorbidities are included. But the most important consideration is this. Insomnia is not a standalone condition. It is now recognized as a major risk factor for depression, anxiety, cardiovascular disease, metabolic syndrome, dementia, and all-cause mortality. You cannot address these conditions adequately without addressing sleep. And here's where I'll get clinically specific, because insomnia has measurable, well-replicated brainwave signatures that distinguish it from healthy sleep physiology. The most fundamental is cortical hyperarousal. In people with chronic insomnia, the brain fails to produce the downshift in high-frequency activity that the onset of normal sleep needs. Specifically, there is an elevated high beta activity persisting through the pre-sleep and the sleep initiation periods. This is a brain that is locked in an overactivated state and can't get out. Quantitative EEG studies consistently show that this hyperarousal pattern is a hallmark of insomnia disorder. Second, there's disrupted sleep architecture. Normal, healthy sleep cycles through predictable stages. Stage 1 and 2, NREM, deep slow wave sleep, or stage 3 that's characterized by high amplitude delta waves, and REM sleep. In chronic insomnia, slow wave sleep is significantly reduced. Delta power, the dominant oscillation of restorative deep sleep, is significantly impacted. This is why insomnia sufferers often sleep the same number of hours, but wake unrefreshed. The architecture is broken, not just the duration. Third, elevated frontal theta waves continue into attempts to fall asleep, the same anticipatory rumination circuit that drives anxiety. The brain continues generating the 4 to 8 Hz activity associated with worry and default mode rumination precisely when it should be transitioning into a quieter, lower frequency state. Fourth, there's reduced sleep spindle density. Sleep spindles, bursts of sigma band activity in the 12 to 15 Hz range during stage 2 NREM, are critical for memory consolidation and not waking up during sleep. Insomnia sufferers show significantly fewer and shorter spindles, meaning that the brain's own mechanism for protecting sleep has been impaired. Fifth, abnormal alpha intrusion. In people who suffer from insomnia, alpha activity, the 8 to 12 Hz oscillation that's associated with quiet wakefulness, abnormally continues into or intrudes on sleep. This is directly associated with the experience of light, non-restorative sleep and subjective wakefulness during the night. The brain is partially awake when it should be asleep. Every one of these patterns is measurable, and what is measurable can be targeted. I want to be direct about what those EEG findings mean for someone who's lying in bed at 2 in the morning unable to sleep. You're not failing at sleep. Your brain is generating electrical patterns that make sleep physiologically impossible. You have elevated arousal that suppresses the delta activity of deep sleep. You have alpha intrusions that keep your brain partly conscious, and the frontal theta that keeps the rumination loops going even as you lie there still. These are not choices, they are measurable states. For the chronic insomnia sufferer, dysregulated brain waves can produce the inability to fall asleep despite exhaustion, waking multiple times throughout the night, inability to return to sleep, sleep that feels light, fragmented, or non-restorative even when the clock says that you slept, daytime fatigue, cognitive fog, and emotional dysregulation that compound across weeks and months of poor sleep, and the anticipatory anxiety about sleep itself, which is a documented phenomena that further spikes arousal before bed. The conventional medical response, sedative hypnotic medications, and sleep hygiene advice, doesn't address any of these brainwave patterns. It suppresses arousal chemically without correcting the underlying oscillatory dysfunction. Understanding this changes the treatment approach entirely. Neurogen brain balancing is described in the peer-reviewed literature as a novel, passive, non-invasive neurobiomodulation modality for brain health. 4 features make it particularly well suited to sleep disorders. First, it's fully passive. There's no screens or cognitive tasks. There's no active effort that needs to be put out. Patients arrive, they sit or lay down and rest while the practitioner in the system does its work. And critically, this means that the protocol can be applied in a state closely approximating the pre-sleep condition. And critically, this means the protocol can be applied in states close to pre-sleep without introducing necessary arousal that task-based therapies require. For a brain that cannot downregulate, removing the demand to perform is itself therapeutic. Second, real-time EEG guidance drives every session. The system reads the person's brainwave state moment to moment, detecting the specific pattern of hyperarousal, alpha intrusion, and sleep spindle suppression present. And then it generates a protocol targeted to that exact neurophysiological state. Third, lip test microcurrent signaling, low-intensity pulse transcranial electrical stimulation, delivers an imperceptibly gentle, highly specific, and adaptive reference signal that supports the brain's own shift toward lower frequency oscillatory states. The peak output is about 2.5 picowatts. That's less than 1/10,000th of the power of a standard AA battery and significantly less than what your cell phone puts out when it's sitting in your pocket, making it well tolerated even by hypersensitive nervous systems. It's not about the amount of power that's used, it's about the specificity. And fourth, neuroplasticity and rebalancing. By targeting the specific oscillatory disruptions that impair sleep architecture, Neurogen supports the brain's path toward the delta dominance, spindle density, and reduced arousal that healthy restorative sleep needs. Now let's map the EEG evidence to the clinical approach. Cortical hyperarousal, the elevated high beta activity that sustains wakefulness, is addressed through lip test signaling that supports downregulation of pathological beta overactivation, reducing the arousal that prevents sleep initiation. Disrupted slow-wave sleep and reduced delta power, the deficit that makes sleep non-restorative even when it happens, responds to neurogen support for the brain's natural shift toward high-amplitude delta states during deep sleep phases. Elevated frontal theta rumination, the anticipatory worry circuit that maintains hyperarousal at bedtime, is addressed by the same mechanism that targets this pattern in anxiety and depression, reducing the slow-wave overdrive in frontal regions. Reduced sleep spindle density, the impairment of stage 2 arousal gating function, is supported through sigma band stabilization, which helps restore the brain's own mechanism for protecting sleep continuity. Alpha intrusion, the persistence of wakefulness during sleep, is reduced through coherence normalization and support for the oscillatory transition that the onset of healthy sleep requires. And dysregulation of the autonomic nervous system, the sympathetic overdrive, and the activation of the fight or flight response, elevated cortisol levels that sustain the hyperarousal. This is addressed through vagal nerve modulation to allow the parasympathetic nervous system to move into dominance and lowering the neurochemical conditions that feeds insomnia. Every measurable EEG signature of insomnia has a corresponding neurogen effect. The primary clinical evidence for neurogen's impact on sleep comes from 2 sources. The 80 veteran observational study published in 2025 in the journal Health reported that sleep disturbances were among the most commonly improved symptoms, alongside anxiety, depression, brain fog, and cognitive function, with 80% of participants reporting meaningful improvement across 4 weekly sessions. Critically, veterans represent a population with among the highest rates of chronic sleep disorder, including insomnia driven by PTSD-associated hyperarousal. The overlap between the hyperarousal EEG pattern of PTSD and a primary insomnia disorder is well documented in the sleep neuroscience literature. The 2026 Neurogen migraine study further documented a 57% improvement in sleep quality as a secondary outcome across only 5 sessions. This was in a population not selected for sleep disorder. This is consistent with the mechanism that as the autonomic nervous system dysregulation resolves and cortisol hyperarousal diminishes, sleep architecture improves as a direct consequence. The supporting literature is also robust. Quantitative EEG studies consistently document elevated pre-sleep beta and reduced delta as core insomnia biomarkers. Sleep spindle deficits in insomnia disorder are replicated across multiple independent cohorts, and transcranial electrical stimulation has demonstrated the ability to enhance slow-wave sleep and sigma band activity in multiple controlled trials. Neurogen targets exactly these mechanisms. The treatment paradox in insomnia is specific, and it's worth speaking to directly. Cognitive behavioral therapy for insomnia, CBTI, is the current gold standard first-line treatment, and it genuinely works for many people. But CBTI requires sustained cognitive engagement, sleep diaries, scheduled sleep restriction, and the cognitive capacity to challenge dysfunctional sleep beliefs. For those in the acute phase of insomnia who are exhausted, cognitively impaired, and in a state of heightened emotional reactivity, this is a high threshold to meet. A significant portion of insomnia patients cannot consistently engage in CBTI in their current state. Sedative hypnotic medications, benzodiazepines, Z-drugs, low-dose antidepressants, manage sleep chemically, but they don't correct the underlying brainwave dysregulation. They suppress arousal without restoring the underlying foundational architecture of sleep. Many suppress slow-wave sleep, the most restorative phase, and some reduce spindle density, compounding the very deficits that drive non-restorative sleep. And the long-term data on safety, tolerance, and dependence is concerning enough that clinical guidelines now recommend deprescribing as a goal. Neurogen removes this paradox. It requires nothing cognitive from the person receiving the treatment. It is directly targeted at the oscillatory disruption, not managing it downstream, but addressing it at the level of brainwave function. It is adjunctive. It supports CBTI, integrates with any medication tapering process supervised by a provider, and complements sleep medicine approaches. And for those who have failed or can't engage in current standard of care, it offers a mechanism-targeted alternative with a passive protocol that's accessible even in acute and severe states. For providers and those suffering from insomnia figuring out if this approach might be a suitable fit, here's a practical guide. Strong candidates include chronic insomnia disorder, difficulty initiating or maintaining sleep for 3 or more months, non-restorative sleep, sleeping but waking unrefreshed, which is consistent with slow-wave suppression and alpha intrusion, insomnia with comorbidities of anxiety, depression, or PTSD, where shared hyperarousal mechanisms drive both conditions simultaneously. For those who are poor responders or partial responders to CBTI, those wishing to reduce or discontinue sedative hypnotic medications under provider supervision, or those with comorbid migraine, chronic pain, or brain fog, all of which share overlapping oscillatory mechanisms and frequently improve in parallel with sleep, and anyone seeking a drug-free adjunctive or primary approach to sleep restoration. The contraindications are narrow. Active seizure disorder requires pre-treatment consultation. Implanted electrical devices require individual review. And Neurogen brain balancing is a complement to sleep medicine evaluation, not a replacement for it. It integrates well along CBTI, sleep medicine, and any prescribed pharmacological approach. The sleeping brain is not a mystery. It is an electrically organized system. When that electrical organization breaks down, sleep breaks down. When it's restored, sleep follows. The measurable EEG signatures of insomnia are not permanent features of a broken brain. They are dynamic oscillatory states. Neurogen brain balancing targets those states directly, supporting the brain's own path toward the architecture that restorative sleep needs. For more information about our integrative neurorehabilitation practice and to schedule a consultation or a session, visit acuneuromodulation.com. For veterans specifically, U.S. military veterans can access 4 free Neurogen sessions through our collaboration with the nonprofit bb4vets.org. I thank you for your time. We're here to help.